information gathered together just in a pile gives you less information than a few things that are organized well. So that's what we're going to go for. The approach I like is, I guess we could call it why sick, which stands for what is it and why should I care? Right? Because I think at the end of the day, that's what this stuff is all about. What is it, whatever we're looking at, why should I care about any of this? And so what kind of tools could we use to determine that? Well, I'm going to say that we should look at the terms that's used, look at the language that's used, and we'll get into applying this in a moment. We need to take a 10,000 foot view. And in this case, we're going to start with a 10,000 foot view of structure and of function. And then act like you're going to explain it to non-medical people. If you do that, you're going to come up with different ways of thinking about it. You know, when I was learning to read cardiac ultrasound or echocardiograms, I finally, it's like I couldn't figure out how is this working and why does it look like this on the screen? And I finally I figured out that it was like taking a blade and kind of arced blade and cutting weird shaped fruits like pears and then lifting them up. Okay, well, cutting pears and cardiac ultrasound, not immediately relatable, but it
loose association.
It sticks, you know, it sticks, and so
that sounds like word salad. I mean, maybe more word salad.
So, you may draw certain conclusions about the validity of psychiatry. Well, no, validity of psychiatry as a medical specialty and the usefulness of psychopharmacology by the time you're done listening to this lecture, but. And the other thing is that, you know, we need to delineate or identify, we need major categories, right? I had a mentor many years ago who said, you know, you got all these facts, they're like hats or something or clothing, and they're just strewn everywhere. You need a rack with pegs on them so that you can hang them up and organize them. And then we just put the details, organize the details, right? Like so. So let's talk about that with the heart. What are the well, I shouldn't say heart, cardiovascular is two words there. So what do they mean? If we were to think about that. Cardiac, right, means heart, the Greek word for heart, and vascular,
blood vessels.
Vessels, not just blood vessels, primarily blood vessels, because you have lymphatics as well.
All right.
So the heart itself, then. All right, so we've got two categories, cardiac and vascular. I guess I can start with. Erase this stuff. We start with cardiac, and so what makes up the heart? Well, it is. It's actually two pumps. Do you know why I say it's two pumps instead of one?
Because there's two ventricles.
Two ventricles, and what do? They pump to different places, right?
Pulmonic artery.
Right, and I'm deliberately trying to avoid fancy medical terms here because again, like if we were just to explain this to, you know, our whoever that doesn't understand this stuff, hey, you know, you got two pumps and they're connected together in one spot, sort of like conjoined twins, right? So you got the left twin and the right twin, and their purpose is to pump. And so we have two muscular pumps. And they go to the, got the left heart, you've heard of that, haven't you?
Mm-hmm.
And the right heart. So where does the left heart pump to?
To the rest of the body.
The body and the brain, right? So body and brain, and this is all in that outline. But I'm just trying to walk through how you can take this really overwhelming amount of material and start to build a foundation. And so where does the right side, the right
To the
heart
lungs and then
pump?
to the left side.
Right. So the right side pumps to the lungs. All right, well, that's looking a little less overwhelming. And these two are ultimately connected to each other by a long circuit of tubes, right? The vessels. Oh, now we got the vascular part. This is getting pretty cool. We're starting to make connections already. So, guess up the heart is two pumps within the heart, and again, because you're supposed to know the anatomy and the blood flow through the heart and so forth, but you look at the big picture. The heart is a pump. It has valves in it to keep the blood going in one direction and not backwards and forwards, and it has to have a blood supply. It has pipes on the top, right? Small pipes called arteries, and it has wires. So the heart is a pump with wires that has pipes. And one side pumps to the body and the brain, the other side pumps to the lungs. Okay, well, I think just about anybody could understand that, whether they knew medicine or not. And so the vessels, there are two kinds of vessels. You guys, I think, have already talked about them. What are the two kinds of vessels? Those that take the blood away from the heart and those that bring the blood to the heart.
So arteries and veins.
Yeah, but I mean, the big picture is toward the heart. Oops. Away from the heart. Away from. And toward, right? Toward from, yeah. Toward. See that? My medication's wearing off. All right.
Somebody needs a nap.
So these are, what are these? What takes blood away from the heart?
Arteries.
Arteries, and what brings blood toward the heart?
Veins.
Veins. Okay. And I'll just touch on the fact, just something to keep in mind. We're not going to elaborate on it right now, but just think about the normal effects of aging on each one of these aspects. What are the effects of aging upon the blood vessels, whether they be arteries or veins? What are the effects of aging on the wires in the heart, the specialized nerve conduction cells? the effects on the valves, the effects on the pump itself. If you start thinking in this manner, then you start seeing pathology and you can say, oh, that's kind of like arthritis of the valve. It gets a little crusty, you know. And no, I'm serious. This is the way you think about it. Okay, now, cool fact, how many times, this is just cool. I mean, this stuff is, I think, is a whole lot better if we can appreciate the awe and wonder factor of it. When you think about this, how many times a minute does the heart beat, roughly? I mean, just pick a number.
60 to 100.
60 to 100. So we'll take 70. We'll just make the math easy. So 70 beats per minute. And how many beats an hour is that then? 60 minutes an hour, right?
Mm-hmm.
So that would be, what, 4,200? Am I doing my math right?
Yeah.
Yeah, 60 minutes, 60 times 70,
Mm-hmm.
4,200 beats per hour. And how many hours in a day?
24.
24. So can you do the math on 42 times 24? Well,
100,000 or 100. Yeah, about 100,000.
100 what?
100,800.
Okay, so we'll just call it, we're going to say it's about
200.
100,000 beats per day. You ever think about that? Your heart beats 100,000 times a day. This dawned on me when I was reading 24-hour heart monitors, and they would talk about total beats and what was the slowest rate and what was the fastest rate and all this stuff. I said, wait a minute, 100,000 beats a day? Let's do some math on that. So how many days are there in a year?
365.
Right, so what's 365 times 100,000? 3.65 million, I think,
Mhm.
right? So 3.65 million, am I doing my math right here?
Well, you just add the zeros to 365. So add 5 zeros to 365.
365,000,000. Oh, it's 36 million. I was
There you
off
go.
by a factor of 10. So 36 million beats a year. That's impressive, right? And so somebody who is 10 years old has had 365 million, except a kid's heart rate is a little faster than this on average, but somebody who's 20 has had, 730 million, and if you're 30, you're now over 1 billion heartbeats in your lifetime. I think that's cool. I think that's absolutely incredible that would be going on. And so that really doesn't have anything to do with anything other than
I don't know if an engine would last that long in a car.
yeah. So, all right, if the heart is pumping, what's the purpose of pumping then? Like, why do I care? Oh, well, that's
Getting
nice, the heart is a
oxygen to
pump.
organs.
Okay, got to get oxygen to the organs and
Take waste away from
waste away
tissues.
from back to where they can get eliminated, right? Which would be
kidneys
and lungs, liver, right? So this whole issue of pressure then, is that kind of important to cardiovascular function?
Are you talking
Right.
about blood pressure?
Yeah, well, what happens if my blood pressure goes down to my brain? If the blood pressure goes down to my brain, am I going to be standing here?
Probably not.
No, I'm going to fall over.
Fainted.
Right. So they the technical term for that is syncope, right? But we can call it passing out, fainting, whatever. Well, fainting is because we've had a temporary interruption of blood flow to the brain. Well, that sucks. We got to maintain a certain amount of level, a certain amount of pressure in the lines, right? And so we're going to talk briefly about the concept of average blood pressure. Okay, so you've heard of the 120/80, right? The classic pressure. Well, do you understand and that, by the way, is all dealing with the left pump, the left ventricle and the body. Because there is a blood pressure that comes from the right side of the heart as well, but it is much, much, much lower, and that's important.
So are you saying that the left side regulates your blood pressure?
No, I'm saying that it has to pump a much higher pressure
Okay.
because of its job. But it's a good question. The right side, because especially when you talk about regulating, it's like, okay, so what does happen to regulate it? And we'll get to that in a little bit. But since the right side pumps to the lungs don't require very much force of flow to get the blood through them. So that's a very low pressure system. So do you have any idea what the number would be for the right-sided pressure?
Is that pulmonary wedge pressure?
Huh?
Pulmonary wedge pressure?
That's something a little bit different. That's the, I don't want to, it's a good
How
question,
efficiently
but
can it pump into the left side of the heart if you have pulmonary hypertension?
less so. It's harder on the right side of the heart, and that illustrates the point
Okay.
that, so if, by the way, do you know what 120 what? Rabbits or dollars? I
Millimeters
mean,
of mercury?
yeah, why in the world do they call it millimeters of mercury? I
Because they
talked
use
about
a thermometer, I guess?
No, I talked about focusing on language. This is a historical fact. When they wanted to see how much force was being generated, they had a little glass tube that had mercury in it. And they said that if the pressure was at 120 millimeters up that tube, then that's 120 millimeters of mercury. So that's it. It was just where
Pressure drives mercury?
the higher the higher the force the higher it would be on that tube of mercury
Okay.
where it would measure. It's just a way of measuring it. I mean, they could have measured it in, I suppose, any number of ways, but again, they were developing this stuff a long, long time ago.
Mhm.
So are you trying to say that the left side is your systolic pressure and then the right side is your diastolic pressure?
No, but that's a good question. Both sides generate their own systolic pressure, and you're doing exactly what I wanted you to do, which was, let's focus on language. What do we mean when we say systolic or systole? And what do we mean when we say diastolic or diastole? So these terms have to take into account the cardio and the vascular. So let's think about a heartbeat, right? You fill the heart, I'm just going to use numbers that are easy to work with for the math. We're going to take 100 milliliters of blood that fills the heart, because in medicine we measure in milliliters, not ounces. But that would be, 3.5 ounces of blood. Now, some people are going to have more, some people will have less, but it makes the math easy. So if the left side of the heart, let's just focus on the left side of the heart because we can illustrate with that. If it fills with 100 milliliters of blood, and then what? The little wires, I call them wires, the nerves, the specialized nerve cells, the conduction system of the heart, gives this little micro zap that flows down the heart, and the heart goes like this, and it's sort of this ringing motion, almost like you would milk a cow, and that it forces blood out of the heart. Not all of it, only a fraction of it. Do you know what we call the fraction of blood that is ejected with every beat?
The ejection fraction.
Yeah, isn't that incredible? The ejection fraction. And a normal ejection fraction, if you want to remember,
It's like 50 to 70, right?
yeah, it's 55 to 70%. But the
Is
idea,
it anatomy? Because I don't remember this.
I don't
No, it's
remember
okay.
it being anatomy.
I don't know.
it's all right. You're going to
I just know it because I have to know when somebody doesn't have a good EF, it means they're going to croak.
Okay.
Right. A weak heart is not going to generate as big of a fraction that it ejects, right? That kind of makes sense.
Right.
If it's not as strong, it might only eject 30 milliliters out of 100.
And you had to get an echo. from
Or
that.
20 out of 100. But so what the systolic pressure is, so basically you're taking a little blob, the term for blob is in medicine, bolus, right? You may have heard of an IV bolus or a bolus of food. Well, you're having a bolus of blood that every time the heart beats, it goes and it squirts out, let's say 70 milliliters of blood into the arteries. Well, that's what causes the pulse. Every time we feel a pulse, it's that blob of blood going boop, boop, boop. Well, the heart, in order to pump that out, has to generate more force for that because there's already some pressure that it's working against. That force is the systolic force, or the systolic pressure. So this is when the heart is contracting, right? Heart contracting. And so what do you suppose the diastolic blood pressure is then?
Filling.
Not filling.
Or resting.
Resting.
When it has the 30% left in it or whatever, right?
Right, but so these numbers really, properly speaking, apply to what you're experiencing in the blood vessels. That's why I said in order to talk about blood pressure, we have to talk about the cardiovascular system. So the heart has to pump with a certain amount of force. It squirts a little bolus of blood out every beat, 100,000 times a day. And every time it beats, we feel a pulse anywhere in the body that there happens to be a little artery. But then what happens after that initial pulse? So like the walls of the arteries go, right? They expand because they're muscular. If they were PVC pipe, they wouldn't do that. But because they're muscular, they're stretchy, they're sort of like rubber bands in a tube. They expand and then they contract. They expand, they contract. Well, you know what that does? Even the contraction of them, it still keeps the blood always flowing forward, which again is really cool. It's not just when the heart is beating that the blood is flowing forward. It's also when the blood vessels are relaxing. So that pressure, when the blood vessels are relaxing, is called diastolic pressure. Now, what we really want to, does that make sense? Okay. What we really want to know is, like, what's the overall effect of these two things together? Because different things can affect these. And so we would like an average. Do you know what the technical statistical term for average is?
Map?
Well, but what's the M?
Mean?
Mean. Right. So what we want is, all right, look, just make this simple. Would you please give me just the average or mean? And since we're talking about the arteries, we're talking about the mean arterial pressure, or MAP. You will hear that term all the time. That kind of makes sense, right? So this average is going to be composed of what? It's going to be composed of some of this and some of that, and then averaged out. So how do you figure out which part of that do you think contributes more to the average pressure? Which lasts longer? The systolic part of what they call the cardiac cycle, or the diastolic part?
Well, I know diastole lasts a lot longer.
Right, and if you think about it, at a normal heartbeat, what is it? It's bump, bump, and you have a pause. Bump, bump. So the bump, bump is going to correspond, those are the heart valve sounds, that's going to correspond to when the heart is squirting out a little bit of blood. So there's more resting time where you're not making noise, bump, bump, than there is when it's going bump, bump. Well, what happens when the heart goes faster? Now the diastolic time period gets less and less, doesn't it? Bump, 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 bump. And if you get somebody who's going 150 beats a minute, bump, 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 bump. Systole and diastole can be the time period that they last.
Indistinguishable.
Exactly, and that's why it can be very challenging to listen to heart sounds during that.
Like SVT?
Sorry?
SVT?
SVT, or children with fast heart rates. But again, these are concepts. They're just going to say, look, a certain amount of, so a cardiac cycle is the time from the beginning of one beat to the beginning of the next beat. And we break that up into systole, when the heart's contracting, and diastole, when everything's at rest. But we just learned that there's a pressure that is associated with both of those because of this incredibly cool thing with these elasticy arteries that stretch back and cause the blood to flow forward. So I'm going to throw this out. You don't need to spend a lot of time thinking about this right now. But there is a formula for mean arterial pressure.
Yeah, she wrote it down here.
Yeah, no, I saw that she had it later on. But to understand why this is important, I'm going to talk about, do you know anything about sprinkler systems? Like, I'll bet you do. I bet you know more than you think. So we're going to talk about a sprinkler system, and we're going to say, so I'm going to say MAP, which is mean or average arterial pressure, is going to be something called cardiac output. That's already kind of making sense, right? The output from the heart. Cardiac output times systemic vascular resistance. Now, I think when we talk about the sprinkler system, or the sprinkler sprinklers that we had when I was a kid, you're going to understand this. And this is what I mean by try and think of things in terms that people who don't know medicine would understand. So I talk with patients all the time, and they get this, and I'll show you why. So mean arterial pressure, I'm going to say that that's the amount of pressure that we have in our sprinkler hose line, right? If you're going to run a sprinkler, you got to have a certain amount of pressure, don't you? Mm-hmm. Otherwise the water won't come out and spray your lawn. I could say the same thing about a power washer, you know, but I think a sprinkler is, to me, it's just easier to think about. So if you're going to generate a certain amount of pressure in any sort of let's spray the water system, power wash at a car wash, or you're spraying paint, or you're trying to water your lawn or whatever, to maintain that pressure, what are you going to need? Again, just think about, I'm going to go back to when I was growing up. We had, they did what they call the sand point, where you would hammer this thing down and get into the water. It's fairly shallow actually where we live, 30, 35 feet under the ground. Boom, you hit the water that was under there. So we had to have water, but how are you going to get the water out of the, you know, through the system, with a pump, right? So we had a well pump, you plug it in and, you know, it chugs around. Well, guess what? That water, that pump squirts out a certain amount of water with every time it cycles, right? Is this starting to sound like the heart? The heart squirts out a certain amount of blood, the well squirts out a certain amount of water. Well, how much it squirts out is going to be based on the dimensions, you know, what kind of pump it is, and also how fast it's running, right? If you're running a slow pump, you're going to have less pressure in the line. If you're running a fast pump, then you're going to generate more pressure. But the other thing is, have you ever sprayed anybody with a hose? Mm-hmm. Right? How do you spray them with a hose? Do you just hold the hose out, or you put your finger over it? You put your finger over it, because if there's a hole in the hose that is bigger, the pressure is less. But by making the hole smaller, you speed up the water, and the pressure has to be higher.
Which is why dilating your vessels lowers your blood pressure.
Exactly, and we'll get into that in just a moment. So are you seeing this? What happens if I have a sprinkler system, I want to water my grass, and I cannot for the life of me figure out, okay, I got a new water pump, you know, new well pump, and I've got a good well, good water source, and everything's dying, you know, I'm away at work during the day. Well, then I go out and I see I got cracks in my hose and they're leaking. So if they're leaking out of the hose, how much pressure is actually in the line of the hose itself? It's going to be low, right? And the smaller the hose, the higher the pressure. But if you make it bigger and bigger, it goes to a lower pressure. And we all kind of know this stuff, don't we? So let's change this into the heart then. The cardiac output, the pump we've already talked about is we talked about an ejection fraction. I mentioned a number. We're just going to call it a stroke volume. SV. And cardiac output is, remember we talked about how many times a minute the heart beats? So, just wait, give you time to write this down. I don't want to talk too fast. And I'll have this on video too. I mean, you can, but I really want it to sink in, because I know you know this stuff. You just have to put different terms on it and sort of let it settle in. So the other thing that we need here is the heart rate, right? So this is beats per minute, and this is some volume that I was calling 70 milliliters to make the math easy. So let's just say this could be 70, it could be 100, who knows. So if we call this 70 milliliters per squirt of the heart, and we're doing that 60 beats per minute, BPM, the total cardiac output is going to be some milliliters per minute, right? Just because that's the way the math works. Now we said in the sprinkler line, if we had cracked hoses, our pressure would be way down, right? There wouldn't be much resistance to flow. Well, in the body, this is where the blood vessels come in, and this is where we talk about the regulation of blood pressure. In the body, the hoses, if you will, what do you suppose those are that the heart is pumping into? The hoses are the arteries, right? Or in this case, the smaller arteries, when it gets from the aorta into the branches and down to what we call arterioles, which are just small arteries that can dilate. What do you think is going to happen if, now to your point, if the arterioles dilate, call that vasodilation, imagine that, that would drop the resistance, right? Would drop the pressure. But if they constrict, what's it going to do? It's going to make them smaller and it's going to jack the pressure up. So, systemic vascular resistance, I'm just going to rewrite this as SVR, and I'm going to call it arterioles. So the way that I like to teach this is to make it practical. You mentioned that I wouldn't, if my blood pressure dropped too much, I wouldn't be standing here. I'd fall and maybe I'd bust my face, which might be an improvement. But why do you think that would happen? Looking at this, so this is where, don't even worry about the notes. Just
a restriction of blood flow.
Yeah, take a look at if this drops, and again, just look at the simple math on this. If this number goes down, it means that one or more of these had to go down, right? That's the only, if this is, I'm just gonna make up numbers. If this is 100, and it used to be 200, again, I'm just pulling this out of the air. Whatever 200 to 100 are, if they're composed of things over here, then if it goes from 200 to 100, that means that something over here had to get lower because there's an equal sign in between them. Okay, so this is so simple that I don't overthink it. So we said in the sprinkler system, if you had cracks in the hoses, well then the resistance, the hoses are like blood vessels, that went down. If the well went dry or half down, well then the stroke volume would go down because I don't have enough water to pump. Or if the pump, we had a brownout or something where the electricity was dropping, or there was some malfunction in the pump and it was going slower, well that would also drop this down. And so this formula is a really, really powerful way. If you've got somebody that has low blood pressure, it can only be one of three things. Something has affected this, something has affected this, or something has affected this. But this also starts to give us a clue as to disease processes. Well, what could affect this? What do you suppose, you mentioned a weak heart before, if they have something called cardiomyopathy, that's a general term for disease of the heart vessel. So somebody has been a heavy drinker for many, many years and it poisons their heart muscles. They've been on meth for a long time, or they just happen to have a familial condition that weakens their heart. Well, what do you suppose that's going to do? It's not going to change the vascular resistance, it's not going to change the heart rate, but it'll drop the stroke volume because they can't pump as much. So their blood pressure might go down. So again, just kind of let this settle in. I don't expect all of this to like just gel instantaneously. This is the sort of thing where you just kind of step back and think about it. So, all right, there's one other important thing. Well, I guess let's give an example. Suppose let's see. Suppose I had a cut, like I had just had it with practicing medicine and, you know, life in general, and you guys happened to come in and you saw that I had a slit in my wrist and I was bleeding all over the floor.
Remember, down the road, not across the street.
Right. And Christine would make sure to teach me how to do that properly, kill myself. But, so you guys would look at me and you would do one of two things. You'd either call 911 or you would say, well, let's figure out why his mean arterial pressure has gone down.
That's what I would do.
Yeah.
I'll probably just call 911 personally.
Well, but it's more interesting to do the physiology thing. I'll tell
Let's
you,
let you
As
bleed
he's
out and
bleeding out.
die.
I'll tell you a true story. So, when Christine noticed that I had some apneic episodes when I was sleeping, you know, like stop breathing, did she wake me up? No, she timed how long they were. Yeah.
She could probably get fitted for
So
some
that
job.
this is not so far fetched to talk about these you know, wrist slicing things.
Oh, okay.
Anyway, but let's just say that you wanted to geek out and say, well, while 911 is responding, why don't we, and we're holding pressure on the wound, maybe reluctantly, but you're holding pressure on the wound. You're saying, well, gee, why did this guy's mean arterial pressure go down? I mean, it's kind of nice because
You got a
he doesn't.
leaky hose.
Well, he doesn't have enough blood to keep his mouth going, so at least he's quiet. But
For real.
but yeah, I mean, it's because I had a leaky hose, but what did that leaky hose do? If you're holding pressure on it, you've fixed that problem, haven't you? Well, I bled out, right? I dropped my volume. And so if you... Hypovolemic, low volume. So if your volume gets low enough because you've bled out, for example, from an accident or from a dysfunctional response to life in general or whatever, then my pressure will go down.
But your heart rate will go up.
But that's the point, exactly. That's the one of the points I wanted to
So if
make.
you pumping too much blood out of your body,
It'll try to compensate.
your
Right.
heart is gonna kill you.
Mm-hmm. It would be.
Well, no, nothing would work unless you shut off the leak. But let's say you shut off the leak. If one of these goes down, the other ones are going to try and go up in a normal circumstance. So again, I'll tell you a very, really insightful thing that a seasoned nurse did one time when we had a patient who she noticed that, and this guy had been in really good shape in years past, so his resting heart rate was lower than mine might be, and she noticed that his heart was going relatively fast on the
For him.
cardiac monitor for him, and she raised a flag. Well, what she was keying in on was spot on, because she knew that fast heart rate could be other things. You could be anxious or whatever, but that fast heart rate could be an indication that the blood pressure is dropping and the heart's trying to keep up and make up for it. And sure enough, she was right. So this is where you guys in your nursing role, and even CNAs, and I try and tell the nursing assistants is, look, the information you're getting is very valuable. If you see a change in the heart rate and it goes from 60 to 120, and we also see that their heart blood pressure has gone from their normal 130 to maybe 100, that's not a good sign. That means that something's wrong and that they're trying to compensate. But are you kind of getting the idea of how you can think your way through this? Well, if you're going to treat that, how do you treat low blood pressure that you think is from low stroke volume?
Give volume. I mean.
Or in
fluid
some way or another increase the stroke volume.
Fluid, right?
Right, depending on, that's why the first thing you're going to do if somebody comes in and they're really hypotensive, you're going to slam them with IV fluid, because we're going to take care of any possibility that this is the case. Get some fluid in there. What if they overdosed on beta blockers and their heart rate is 25? Is the problem primarily volume or primarily resistance? No, the problem is heart rate. So now you have to find a way to address that, which might mean putting a temporary pacer on them. Well, yeah, I mean, you might give them, what'd you say?
Epinephrine.
Yeah, I mean, you might give them a chemical pacemaker
But I guess
so to
that
speak.
doesn't last, it's a short half-life.
Right. But you're going to give them something to raise their heart rate, and to stabilize them, you might even have to put pacemaker pads on them if other stuff isn't working.
Temporary pacer.
But the point is what you're addressing there is the heart rate. Okay, so you're getting an idea that by understanding, goes back to that method thing, by understanding the normal function and structure of this, even on a pretty basic level, you can suddenly start to think your way through this pretty effectively. And I use this stuff again and again and again and again in my practice. This never becomes obsolete. So, a little introduction to that. Now, going through, the big picture view, I guess, the more we understand of how things work and why, at least a little bit, they're working the way they are, then if we see a patient with certain symptoms, like their lips are blue, or they're just not thinking clearly, they look kind of, like that, or they've got ulcers, on the sides of their ankles, and what could be causing that kind of thing. As we go through this, we get a better idea of, all right, well, let's make a list of possibilities. And that's where in that video, and I suggest you watch this, it's a fairly short video that's up on the Educational Outreach YouTube channel, the one called Dog Pee, Wheezing, and Global Warming, how a medical test works. You make a list of possibilities. So in that video, what I said was, if my carpet stinks, because we think this way in real life. If the car is making noise, we take a list of possibilities. Martian invasions is probably way down on the list. Electromagnetic pulse, or whatever they call it, EMPs, probably way down on the list. Loose screws, that's probably higher up on the list. Crack something, whatever. You make a list of possibilities, and then you go to test them to see which one it is, so you can try and fix the problem. Same thing in medicine. And so, how you create this list is going to be informed by your understanding of some of this basic stuff. So you looked at me, let's say you didn't see blood all over the floor, and you didn't find sliced arteries on my wrists, but my blood pressure was low. Well, then you're going to look probably for other causes, unless you think I'm bleeding inside my body. Anyway, do you know what you call that list of possibilities of whatever might be going on? But it does raise a good point. I mean, it's a good case to consider. Differential diagnosis. And differential in kind of an older, well, it's an older sense of the word. This is why I say look at language. If you talk about a differential, you've heard the term differentiate. You're trying to distinguish between one thing and another. So a differential diagnosis is a set of different diagnoses. We could call them hypotheses, we could call them possibilities. And that's why I say some of them, if somebody comes in with, in the case of the carpet, if the carpet stinks, my differential diagnosis might include the dog peed, or I spilled something on it, or something leaked from the bathroom, or global warming. Well, of those four possibilities, which is the least likely in that differential? It would be global warming, right? Mm-hmm. And so the most likely would probably be the dog peeing. But if I found out the dog hasn't been in the house at all, then that's going to take that to a lower possibility. You see how this kind of works? It's very fluid. And this is why we always have to be thinking, there can't be this, if this, then that, it must be this. That's a potentially, you could say it might be this, but what's the likelihood? What's the probability? So, how do you determine probability? And I'm trying to go from here into some of the stuff then that was in the lecture, or in the slides that I looked at from your lecture, because a lot of it is diagnostic, right? They talk about where you listen with a stethoscope,
Yeah.
or they talk about doing EKGs or cardiac MRI or chest x-rays, or asking the patient questions about their risk factors or their history or whatever, where their symptoms are, how long they lasted. Do you know what all those things have in common? They're all forms of testing.
Oh, asking questions?
Everything, yeah. And this was, I wish somebody would have taught me this because it would have made it so much more interesting. You know, you go down this list, and it is important. You have to learn a lot of techniques that you may or may not use, but at least to be exposed to them. But if you understand how a test works, or even what a test is, I mean, what would you call a medical test in the broadest sense? Huh?
A diagnostic test?
Yeah, it's something that is going to hopefully help you diagnose a disease. But in the broadest sense of the word, a test is just something that gives you information, right?
Yeah.
So what can give you information that would be medically relevant? So let's go through the different types of tests. And when I say this, I'm talking about just in big picture terms, just like you could explain to a grade schooler or somebody who doesn't know anything about medicine. So I'm going to
Stress test,
say,
nuke med.
okay, 1 second. So I'm going to say a test is something that provides information, right? Does that make sense? Something that provides info is a test.
Okay.
Okay? And in this case, actually info about what? If I'm diagnosing my car, as you said, is to give us a, push us in the direction of diagnostic or diagnosis. If I'm gathering data about my car problem, then that would be a test relevant to the car. If my ice cubes in the freezer are melted, then I want to diagnose the refrigerator. But in this case, we're doing medical tests. So what things can provide us with information? What provides info? Or what could provide info? What do you think? If I'm saying anything that provides information is a test. So what could bring that to our attention?
For what? For a human? For a
Yeah,
car?
for medical. For medical.
Well, blood, drawing blood.
Okay.
Lab tests.
So we're going to say
Chest
lab,
x-rays, sputum samples,
X-ray,
urine samples,
sputum.
how the patient presents, so like a
What does that
doorway
mean?
assessment.
Your what
A
assessment?
doorway assessment,
What does that mean? What's a doorway assessment?
where you look at them and
Eyeballs. Eyeballs provide you with information. Eyeballs. So what we see. What I'm really focusing on here is the ways that this information comes to us. So I'm going to lump these under fancy diagnostics. And the reason I do that,
so like
So
objective
in-
and subjective.
So, like in your nursing term here, your assessment would provide you the best info.
it might,
Is what you're saying?
well, it might, but I just want us to think about the fact that every single piece of information that comes to us about the patient is a test. It's test data. So, and I'm saying, well, how do we get that data? We can get it with our eyes, get it with our ears, get it, fingertips and hands, like feeling pulse or palpating on physical exam. Here I've said fancy diagnostics. What else?
A patient's subjective report.
What the patient says. So we'll say patient history. And when I say history, I don't mean like, oh, I had a heart attack 10 years ago. That could be relevant too. This could be the the technical term of, I know you've heard this, but have you heard of a history of present illness? So a history of a present illness, or an HPI, means what's the relevant information
Why
about...
are you here, fool?
What's that? Yeah, why are you here? Well, 27 years ago, I had a...
They all do it though.
I had a fracture of my left ankle. Now, sometimes that's relevant because if they come in complaining of an ankle pain, their fracture 27 years ago may have some connections. But
No, you're not that lucky.
But the present illness, so the history, or it could be past medical history. All right. So let's see. So fingertips, hands, eyes, ears. And when I'm going to put this under patient history is either going to be what they say or questions.
I mean, technically the smell too, because if they have the diabetes, they're gonna
This is
smell like
true,
the
the
diabetes.
ketones.
Technically what?
She's got a good point. Smell. Because if you smell ketones or...
They smell.
Oh, smell,
Halitosis.
very good. Now, one thing that may come in as well, the patient's family, right?
Sometimes.
So they sometimes can provide you with critical information. If somebody's acting some way and they denied to you that they were alcohol users, and then they start acting funny and get delirious, and family or friends come in and say, no, you need to realize they drink a fifth of whiskey a day. Well, that's going to take your differential diagnosis and run it in a much different direction, right? You're going to think, wow, this is probably alcohol withdrawal. So how do you know which test is the best test? If these are all tests, because you asked the question before, you know, the nursing assessment is probably going to give the best information. Initially, absolutely. It's also the simplest to gather, but what I'm saying is, when I said I wish I would have been taught it this way way back when, much of my teaching has to do with my own frustrations of why couldn't somebody have done this 30 years ago. When you realize kind of how this game works, then you learn better how to ask relevant questions, and I just think the whole thing becomes more cool, because then you're not just listening for listening's sake.
I don't think there's any one best test though.
You're
is there?
exactly right. There is no one best test. The right test is going to be context dependent. So what may be an excellent test in one setting may be a terrible test in another. Let me give you an example. Somebody comes in with low blood pressure. They're 16 years old. They passed out in the shower. They look pale. You're already, just knowing that information, you're already going to be constructing.
Orthostatic hypotension.
Oh.
Or
But you're already going to be constructing a list of things in your mind, right? Of what this could be. You don't know, so you're going to get more medical testing. Were they in a motorcycle accident? Were they out with their friends? Do they have, you know, maybe you probably
Do they play
wouldn't.
sports?
Sports or whatever. Like, you need to know context. You need to ask history. Well, if they're kind of loopy, you may have to get this information from the patient's family. But one of the things I'm trying to steer away from is that we have been conditioned in healthcare and in a society to think that if it's a fancy diagnostic, and I mean, we could really add to this list of MRI and EEG and EKG or ECGs that drive Christine nuts, et cetera. All these things, oh, this is the real testing. Well, no, it's not. This can be worthless. So any test that I do, I'm going to want it to change my opinion.
Well, because pediatric EKGs will show an MI almost every time.
Yeah, if you interpret them as they would for an adult.
Yeah.
But the whole point in getting a test, once we've got this list of stuff, possibilities. So we got this young patient who has come in, their blood pressure is 60, right, and it should be 110, young man or whatever. And we're thinking, well, shit, what could this be, right? You're getting a little nervous and we can't get any good information out of him. Well, we don't. A urine test is probably not going to be much better than a flip of a coin, right? It doesn't change the probability of what we think before and after the test.
But what if he comes in, everybody's denying that he's done some kind of illicit substance?
Right.
Wouldn't you want to get a urine test?
Very good point. So
I don't know that you could exactly rule that out as being a worthless
Right.
test. One way or another it has.
Right, and very good. I was thinking urine for infection.
Oh, I was thinking urine for.
And you were thinking urine for drugs, so
yeah.
that's
because it would explain at least something.
Right. No, your point is spot on. And here's the thing. So it illustrates this perfectly. What I'm getting at is every test has a pre-test probability and a post-test probability. Right? And all that means is
what does that even say? He does write like a doctor.
does this. It says really.
It looks like something Joe Biden would say.
Yeah.
So you can see that, well, you can't see because you can't read it, but let me try that
A
again.
doctor scratch.
I don't know. Drew used to make fun of me for the way I wrote on the board too, but let's see.
Well, do they don't you have to take a handwriting class in doctor school so that you can learn how to write in
I think it's genetic or something.
Is it?
All the intelligent people get the bad handwriting is what he's trying to say.
Can everybody read this?
You need to get in the paper with the lines.
Pretty good. Okay. So pre and post test probability, what does that mean? That means that there's no point in doing a test if it doesn't make me any more or less sure about a diagnosis afterwards, right? What's the point? If I'm going to say, well, I think this person may have had a heart attack, and so what I'm going to do is check their intraocular pressure to see if they have glaucoma, will that change my post-test probability about heart attack? No, because it has nothing to do with the heart. But if somebody has blindness, then doing an EKG is probably not going to do me any good, but testing their intraocular pressure may have some relevance. I mean, I'm not an ophthalmologist, but and so that's why in this really funny illustration, if you watch, Christine and I have watched this Dr. Glaucomflecken, and he's an ophthalmologist that makes fun of everything in medicine, including ophthalmology. And he talks about going to the ophthalmology team responding to the trauma patient in the emergency room. So they go in there, and he calls this part of the body the organ container. And so the team comes in there, right? And this is a gunshot wound or something. And the ophthalmology team comes in and they're checking the pressure inside the eyeballs, right? And it's silly, it's ridiculous. That would be like, well, why don't we check their toenails and see if they're
well manicured?
Right. A good test will change your post-test probability. Otherwise, it's not a good test. How do you determine what a good test is? It's all about context. So if the family's information is that, oh, no, this person didn't do drugs, and you're like, this isn't making a lot of sense, and then you do a urine drug test, and your urine drug test pops positive for something that could cause those symptoms, now your post-test probability goes way up, whereas before it was pretty low.
But why would you even think to do that test if your pre-test probability was so low?
And that's an excellent, excellent question.
I feel like a lot of tests would get missed because you wouldn't think to do it. It just seems irrelevant.
It depends on if we gather information and we still can't get a good idea on what it might be, that's when we have to start saying, all right, well, we better gather some more data and just gather it in, I'm not going to say a shotgun approach, but you're going to spread the net more broadly because you just don't know. Because then you start looking at, well, I don't know, could this be this, or am I missing something? Well, I didn't order this blood test, I normally wouldn't, but I'm going to throw this one out there in case I get something, out of it. But did you have a specific diagnosis in mind? No, I'm sorry. I
Yeah,
had to
it was
put that
just
on
a
pause.
16-year-old girl that was brought in by people who had seen her on the street. She was confused. We had no idea what was wrong with her. We did, I think they did a urine, they ran labs. I mean, and while the labs were inconclusive, I don't remember there being anything that just jumped out at us. She ended up she was very febrile. I think it was like 105 or 106. But we still didn't really know what was wrong with her. So finally they decided, well, let's just do an LP and see if that is something. So LP wasn't on the pretest probability list.
Right.
But we did it, and it turned out that she had meningitis.
Excellent.
Of course, we all had to get treatment for it because none of us knew it, and we were all exposed to
Right.
it. But again, to the point of, you don't really know what tests would fall under the pretest category, because it's weird. We have no
Right.
idea what to start with.
No, and I think that's an excellent case example to illustrate this. That actually gets us back to earlier in our little talk here about, if the more we understand about how stuff works in general, the more we can then say, okay, well, we didn't think it was this. Let's step back. What even hypothetically could cause this? And then you go down a list, and they have different mnemonics for it, that you start thinking in categories. Could it be cardiovascular? Could it be infectious disease? Could it be drugs or toxins, medication, and so forth? And then based on that, you say, well, okay, if theoretically, let's just say this could be an infection. Well, we haven't seen anything else that this could be. Is there a kind of infection that could cause this? Well, what about central nervous system infection? That's how the thinking would go in that. Rather than, ideally we're not just throwing darts at a wall and hoping that whatever it hits might be the diagnosis. So with these things in mind, then, when you look at when you're assessing a patient, and this is why I think this is, to me, it makes this so meaningful, because now when you're listening to a patient's lungs, you're going to be thinking about certain things, and you're going to be saying, well, what's the relevance of listening to somebody's lungs if they're there for a foot infection? Probably not very relevant, but there is one thing to keep in mind, and again, I know Christine knows this because she's heard me say it 1,000 times. For any test that you have, any test where it's gathering information, even questions, what is the most important test?
The previous test.
The previous test. Now, why would the most important test be the one before it? Baseline, yeah. So now all of a sudden, even these, like, oh, please shoot me, do I have to do this assessment again? Well, if we think about it in terms of, yeah, this is incredibly boring because there's nothing wrong with it, but it's going to give me a baseline. This is what happened the other night that I was telling you about, that I had a nurse that heard crackles in a patient's lungs and knew that, read in the chart, they had a piece of history that said that they had heart failure. Well, I mean, and they're getting IV fluids. Well, then you might think they're in heart failure because they're getting too much IV fluid. But unfortunately, the information that she had was incomplete, and that's where, if she would have been able to have had the other information. So I don't fault her for suggesting a very reasonable possibility of heart failure, the crackling lungs and the fluids building up. But what if you found out that the last test, meaning the lung exam, was also crackly? Or what if you found out that they also came in and they were actually too low a volume because they'd been sick and hadn't been eating and drinking? Well, now your probability of heart failure is going to go down, down, down.
A little bit.
And you're going to be thinking of other things. Yeah, I wouldn't say it takes it off the table altogether. It's going to depend on how much fluid they have.
Unless you come up with some other ideas of what it could be that are viable, or that are not viable, that are realistic, I would still, I guess, if a nurse called me down to assess a patient for crackles that they heard, and I heard the same thing, and I also saw in their chart they had a history of CHF, and well, okay, I acknowledge that they're here for hypovolemia, I get that, but it sounds to me like we may be fluid overloading them. I would think the same thing.
No, and I'm not faulting that. I think that that's a very reasonable thing to think, but I'm saying that the probability that they're fluid overloaded if there is the information available that says, oh yeah, the last exam when they were admitted before they got IV fluid, they were also crackly. Well, now...
How do you explain that, though?
Well, you have to explain it through something different, but at least we can say, well, I think the likelihood of heart failure is low.
So why were they crackly the last time then if they were...
Precisely.
That's what I want to know.
Precisely. And, but whatever the reason, what we don't want to do is to say, well, it must be that because these crackles are there. I mean, maybe if we had the luxury of looking back at this patient's clinic chart, and for the last 5 years, everybody who listened to their lungs heard crackles, well, now we're thinking some chronic condition, right? And so this is why the prior information is so important. Mm-hmm. If you have an EKG that shows something just awful and you feel like you're going to wet yourself because it's so concerning, but the prior EKG showed that, and 5 years ago it showed that as well, well then that's entirely different than if the last EKG is normal and now you're seeing these big changes that could suggest, whatever.
Mm-hmm.
So just like stating this, like this stuff would be helpful on a question that's like, these are the patient's symptoms, so. What test would you run?
Absolutely.
That's
absolutely. But in order to know what test to run, you got to know something about the normal structure and function, and that's why I said let's look at this from 10,000 feet, and then let's kind of break it into broad categories. There's cardio and there's vascular, and within the cardio there's the pump and the little nerve cells that supply the heart and the valves and so forth. So we have to learn a certain amount in order for this process to work, but the more we add to our knowledge of that, the better we're going to get. But I will tell you, this process never ends. I mean, people that are very, very good at this, who are extremely knowledgeable, still go down the wrong trail. And this is again why I teach my staff, look, I want all of us to be thinking according to the same pattern. Nursing assistants or nurses are not going to think it. They shouldn't be expected to think at the same depth or breadth that a physician is, but using the same kinds of principles, you get, that's when the team really gels and works together well. And that's when the patient gets the best care. So let's talk about, say, peripheral vascular disease, and let's walk through at least what I think I'm getting are the way of thinking through that pathophysiology map. So if you were to talk about peripheral vascular disease, again, unless it has somebody's name attached to it, like Birger's disease or Raynaud's disease or whatever, that makes, like, it doesn't tell you anything other than it was named after somebody like that, Parkinson's or, okay, well, that, it is what it is. But if we talk about things like myocardial infarction, well, that means destruction, death of a tissue, in this case, the myocardium. And so that's a very helpful term for a disease. If we look at what I'm looking at on the screen now, peripheral vascular disease, we look at the terminology there, and it's a disease of what?
Vasculature?
The vasculature, and of what vasculature?
The peripheral?
Peripheral, exactly. Okay, well then we know we're probably talking somewhere out more toward the perimeter of the body, right? Mm-hmm. Instead of like the extremities. Makes sense? I mean, this may almost seem silly because it's so obvious, but I'm just saying it to reflect on it. Well, then it's broken down into peripheral. Well, here they have it broken down into the two different kinds of vessels, arteries and veins. So again, we learned earlier that the vasculature is composed of arteries, is composed of veins. That means that things can go wrong with either one of them, right? So if it goes wrong with the veins peripherally, it must be a peripheral venous disease, and if it goes wrong arterially, it must be peripheral arterial disease. Imagine that. Mm-hmm. Okay, and then they break it down into different classifications and so forth. But let's, what does the sheet call for it? It says, so we talked about the name, we're just going to pick peripheral arterial disease. So what would we want for the risk factors? What could you identify as the risk factors for peripheral arterial disease?
Risk factors?
Yeah.
Well, probably overweight and unhealthy diet,
Okay.
sedentary.
All right.
Maybe.
I guess backing up, what is peripheral arterial disease? And how would you describe that in maybe layman's terms?
I'm not even sure if I could.
Right? Well, you have blockages of the peripheral vessels to some
So
degree.
plaque?
Some degree or another. I mean, this is generally what we're going to think of as
So hyperlipidemia, is that a...
hyperlipidemia. So if we're going to talk about risk factors, we could say maybe lipids.
That looks like renal failure.
No,
It's okay. It's okay.
risk factors. So lipids, there's a big one here that's huge. It always comes up for risk factors.
Cholesterol.
That's lipids.
There's
Big one. You know it.
overweight.
Yeah, but I don't know
That's
that
not a big one. You're a big one if you're overweight, though.
But what's one that comes up all the time?
Smoking.
Smoking, yeah. So smoking.
Why didn't I know that one?
Smoking screws up the blood vessels. We'll just say that. That's the technical term. It screws them up. So it just creates all kinds of free radicals that just wreak havoc on the lining of vessels.
Mm-hmm.
What else might be? Are there any other disease states that would be caused?
COPD?
Not that I'm aware of. And again, these are going to be organized in kind of a hierarchy of some are higher contribution of risk than others.
Diabetes?
Diabetes, excellent. Diabetes. Right, so diabetes. So you want to talk about somebody who wreaks havoc on their blood vessels. A diabetic smoker.
Neuropathy.
I mean, this after a while, you'll be able to create a scripted patient based upon the diabetic smoker and the symptoms they might have. Okay, so without, you could probably family history, right? And family history can be a very strong one just for vascular diseases in general. And so, again, that's going to vary and it can be hard to predict because you may be the person that doesn't get as much of a contribution. But if dad and 3 brothers all had MIs in their 40s and youngest brother is 39, there's a really strong likelihood that no matter what he does with his health going into his 40s, he's going to have issues, as an example. Even if he's not a smoker and all these things are there.
I'm getting the cancer.
You're getting the cancer?
So
Me too.
anyway, what is the other question? We talked about risk factors. We talked about potential complications. All right. Well, so if this is just the kind of the plugging up of the arteries, then let's just let's say I have this in my right leg, and the arteries are getting more and more clogged slowly. What's that going to cause? What kinds of symptoms? What kinds of...
It's going to cut off oxygen to your tissues.
Cut off oxygen.
Cause ischemia to your tissues.
Right, and now we're getting into the pathophysiology, so that's good. So decreased oxygen to tissues. And I'm sorry, you said something else, I think?
Causing ischemia.
Right. If this gets narrow enough, if it goes down enough, it's going to cause ischemia. So what is ischemia? We've heard this term myocardial ischemia, cerebral ischemia. You can have hepatic ischemia. So ischemia is what is produced when there is a reduction in the blood flow, or the oxygen specifically, the oxygen to a tissue. Infarction is when that goes to the point where it dies. So, well, that part of the tissue dies. So when you've heard, this is why I hate the term mini stroke. They talk about mini strokes. It sounds like it's benign. Yeah, that's a terrible term. Yeah, TIA stands for transient ischemic attack. Stroke, which is an unfortunate term, I don't like brain attack either, that's in vogue now. But cerebral infarction is a good term.
Is that what happens in a TIA?
No, a TIA is headed towards a cerebral infarction, but it doesn't get there. It's just like in the heart.
So it's a pseudostroke?
Well, what happens in the heart when you have you have impaired blood flow, but not so much that it kills the heart tissue. You have ischemic symptoms.
Yeah.
Same thing in the brain. So you have temporary. That's why it's transient. It doesn't do the permanent damage, but that's not a benign thing, and that's why I don't like the term mini stroke. But if you have interruption that lasts long enough that it actually causes destruction of the downstream tissue, well, now you have infarction. That's a cerebral infarction. Old term, cerebrovascular accident, stroke, whatever you want to call it. Same thing in the heart. If it's myocardial ischemia, that's reduction of oxygen to the heart tissues, and that develops certain classic symptoms, but not always. What happens if this, you said this could cause ischemia. Where would the ischemia in this case be? It wouldn't be in my heart or my brain.
Maybe where it's cutting off your blood supply.
Yeah, wherever the blood supply is going. So that's going to depend upon what the level of blockage is, right? If I've got blockage up here in my iliac artery, or my femoral artery, or popliteal artery down in the knee, that is going to have implications for what symptoms I would or wouldn't have. So what happens when you impair oxygen to the heart? What kinds of classic symptoms do you get? Chest pain, chest discomfort, shortness of breath. You feel awful, right? Well, what happens when you deprive a muscle, whether it's to your butt or to your thigh or to your calf or to your foot? What do you suppose you're going to feel there when you've impaired the oxygen supply?
Probably the same.
Yeah, pain. Do you know the term for that pain? She did mention it in the slide. The term for that pain is called claudication. So you walk. Why would claudication or that kind of ischemic limb pain happen when you're walking and not at rest in many cases?
Because you're using the muscle, you're contracting it.
You're requiring more oxygen.
Oh.
Yeah. And so, but you're right. You're using it, and in using it, you're putting more demand on it, and in order to meet that demand, you got to get more oxygen to it, but you can't.
Which increases blood flow.
Right, you can't increase the blood flow because you got this tight vessel. And that can get so bad that people can even have it at rest. And when you have resting limb ischemia, well, now you're in danger of losing the limb to, infarction or death of the tissue. All right, so we talked a little bit.
Can this cause like tissue necrosis?
Yep.
Okay.
Yeah. No, and people will get gangrene if they have this. So if this condition, it's generally, this is a progressive thing. If you abruptly block off the artery, which does happen, you can get an arterial embolism in a variety of conditions. It's uncommon, but it happens. Well, that's a vascular emergency, because if you don't get that clot out of there, everything south of that is at risk for dying. That's different than something that's developed over the last 10 years. So we talked a little bit about pathophysiology. What do you think of the complications could be of chronic peripheral arterial disease? If you're chronically undersupplying your foot, what do you think you might develop? Think of the diabetic that you mentioned. We see this all the time.
We might have ulcers.
Yeah, ulcers, right? Their wounds don't heal. So you could get foot ulcers, and the same happens with venous ulcers, but they tend to have differing, if they're venous, they tend to be on one side. If they're arterial, they tend to be on the other. But without diving into that too much, this is kind of how you would think. Signs and symptoms. We talked about how you could have, when I walk, my butt really hurts, but it goes away when I rest. Whereas somebody else says, man, I hurt, but when I walk for a while, it gets better. Well, that's a test, by the way, that information that we just got from that person. If their pain in their butt or leg or whatever is going away when they walk, then the probability that that's peripheral arterial disease
Goes way down.
goes way down. Your post-test probability, what was your test? The question. It's just a question.
Mm-hmm.
And by the way, the 16-year-old that I mentioned before, well, you mentioned an excellent point of maybe they're doing drugs and we don't know about it. Or something happened to them and they got, essentially a poisoning. Or, in which case an MRI, even though it's a very fancy condition, is going to be useless, but a simple urine test might be a make or break thing. What if you found out they were allergic to nuts and like we would never, normally I don't care what they had for dinner, right? I mean, it's not going to matter, but wait, they're allergic to nuts. Oh, now that's new information. Now my probability that this might be related to peanut allergy goes way up. I'm gonna do one more test. If they can talk to me, did you have anything that might have had nuts in it? Oh crap, I had that candy bar or whatever, it had nuts in it. Boom, you made your diagnosis.
Mm-hmm.
So, signs and symptoms, we talk about pain, you could talk about what? Decreased flow. If you're going to feel, what do you think the pulses in the top of the foot would feel like? We said every time the heart goes
They'd be
like
weak and
this.
thready.
Yeah.
If you had any.
If you had any. Because every time the heart beats, it should be giving us a pulse. And so I think you can kind of fill in the blanks for the nursing interventions here. And the testing, do you think you might want to know something about the degree of restriction in the flow? Ankle brachial index, they're going to compare the blood pressure taken from here with your ankle, and normally they should be within a certain ratio. It's a pretty simple test, but you get the idea. You're just saying, wow, there's a pretty impaired flow down south. On the other hand, if the ankle brachial index is normal, then the idea that what you're looking at is peripheral arterial disease is going to go way down.
Mm-hmm.
So that could be a diagnostic, but as you said, the nursing implications, you might look for ulcers, you might look for infections related to the ulcers. What can happen with foot ulcers in particular that can be devastating over time?
Foot amputations?
Well, yeah, because
they don't feel it, and so it never heals.
Gets into the bone, right?
Yeah.
It can get into the bone. And so, anyway, I think you get the idea there, and that's a lot of information, but hopefully that gives enough of a framework to try and start to wrap your head around this a little bit. And now when you work through stuff, it's not just this chapter, any chapter, lungs or urinary or kidney or any other system you study.